Oh, yung klase ko. Okay na. Pasensya na. Okay na siya.
Yes, Doc.
You can already see my screen.
Yes, Doc.
Sige. And then pulmonary ventilation, diffusion of oxygen, transport of oxygen and CO2, tissue gas exchange, regulation of ventilation. Functional anatomy of the respiratory system. Your respiratory system involves the nose, from the nose towards the lungs. Diba? You have your nasal cavity with your concave, you have your nostril, and then the mouth, the hind part of the mouth, the larynx, and this is your pharynx, considered your pharynx. Then your trachea, no? The trachea branches into your two bronchi. Into two, and then four trachea into two, right and left bronchi. Okay, and then you have four. From 4, you divide into 8, and then 16, into 32. And then into your terminal bronchioles. Then your respiratory bronchioles. This is already your respiratory zone, alveolar duct and your alveolar sac. Okay, your alveolar sac, when you spread it, it can cover one tennis court. That is how wide it is. So in your respiratory passages, you have 20 generations of branchings. Okay. So this is your respiratory system from the nose to the alveolar area. Gas exchange occurs only in the alveolar area. That's why, and there are 300 million alveoli here. Your alveoli is being enfolded. You notice it is being enfolded. Why? So one sac here, one alveolar is enfolded like this. That is to what purpose? To increase your surface area. So you'll have more area to exchange your carbon dioxide and oxygen. Okay. And these are your capillary endothelium. Your capillary endothelium comes in contact with the alveolar sac. Your oxygen from the outside, from the alveolar area, it will go to your erythrocyte and specifically to your hemoglobin. Okay? So you have 3 million alveoli. No, there is no communication between the right and left intrapleural fluid. You have your visceral and your parietal pleura. The visceral pleura is the one attached to the surface of the lungs, this one here. And the one attached to the interior of the thoracic wall is your parietal pleura. Now, it involves pressure. And this, by the way, they don't communicate, okay? And this one, this is a space, but very narrow. Do you imagine your glass slides when you wet your glass slides and you let it come together and then they slide, right? This is there's just a potential space at first. So when they slide together, they actually come in contact, but there is a potential space here. So that when there is a pathology, this can be filled with fluid. Your space between the parietal and the visceral pleura. Alveolar pressure. Inside the alveolus, imagine this to be an alveolus. This is a diagrammatic representation, of course. Outside in the atmosphere, the pressure is 0 millimeters of mercury. Inside the alveolus, we have the same pressure, 0 millimeters of mercury. That is, if it is at the end of expiration, because you have two phases, right? When you inhale, that's inhalation, and then exhalation. The alveolar pressure is the pressure of air inside the lung alveoli. It is abbreviated P, alveoli. The pleural pressure, intrapulmonary pressure, is the pressure of the fluid in space between the lung pleura and the chest wall pleura. Okay, and there is a space here, potential space. The pressure here is negative. The atmospheric pressure is 700 surrounding body, and at sea level is 760 millimeters of mercury. So this is considered, the reference value is 0 millimeters of mercury. Now the transpulmonary pressure difference between, it is the pressure difference between the alveoli and outer surfaces of lungs. Between the alveoli and the outer. You get that. This is a measure of the elastic forces in the lungs that tend to collapse the lungs, also called your recoil pressure. Your alveolar pressure minus your intrapulmonary pressure, that is your transpulmonary pressure. This is the pressure difference between the alveoli and the outer spaces of the lungs. So here, 0, the intrapulmonary pressure is normally 4 millimeters of mercury. And so 0 minus 4, that is minus 4 millimeters of mercury. The pressure difference holding the lungs open opposes the inward elastic recoil of the lung, your transpulmonary pressure. It opposes. So since it is positive, this one is negative. When the alveolar pressure is greater than the atmospheric pressure, air from the alveolar exceeds. When the alveolar pressure exceeds, when the alveolar pressure inside is lower than that of the atmospheric pressure, air enters the lungs. So alveolar pressure should be -1 so that air can go inside the alveoli. That is your inhalation. It's more or less like this. Your Boyle's law is P1 V1 equals P2 V2. When you compress, you add pressure, right? So the volume will become smaller and your pressure is increased. So this is compression. When you increase the volume, the pressure is decreased. Okay, that is decompression. That is your Boyle's law. So that's it. So your air from the outside will go inside. Flow equals pressure from the alveolus minus the atmospheric pressure over the radius. So if alveolar pressure minus the atmospheric pressure, so that will be lower than the atmosphere. So air will come in and oxygen will flow towards the blood vessels. The carbon dioxide, on the other hand, will come in from the capillaries towards the alveoli. So the alveolar pressure will be increased. And what happens? Increase greater than the atmospheric pressure. So what happens? The air will go out. So that is your expiration. We'll discuss more about that. Breathing is brought about by increasing or decreasing the vertical, the antero-posterior, and the horizontal diameter. You just of the thoracic cage. Just imagine the pail. Yung balde, it has a handle, right? So that goes to the horizontal diameter of the thoracic cage. When you pull it to the side, or when you try to carry it, the pail, you adjust the handle, right? So that is the horizontal diameter, and then the vertical, and then the antero-posterior. At the end of normal expiration, what happens? How many muscles are involved here in your breathing? You have your external intercostals, you have your diaphragm, you have your internal intercostals, and your rectus abdominis. Your main muscle for inspiration is your diaphragm. Expiration is automatic recoil of the lungs. But when there is, what do you call this? When you need to exhale farther, you need your rectus abdominis muscles to depress the thorax. Okay, so that your diaphragm will go up. So because it is like this, with the help of your external intercostal muscles, at the end of normal expiration, this is a normal. The diaphragm is relaxed and the external intercostals are relaxed. At the end of, so the air will come in, okay? The sternum moves up and out. The external intercostals will pull the ribs up and the diaphragm will contract. When the diaphragm contracts, what happens? The diaphragm will go down. Okay? So the lungs is inflated. At the end of expiration, normal expiration, there is a recoil of the lungs. So the sternum moves in and down. The internal, this time it is the internal intercostal muscles that pull the ribs down and inward. And the diaphragm moves up, okay? If there is a forceful expiration, the rectus abdominis will come into play. It will depress and push the thorax up, no? And push the diaphragm up. So that is the appearance of the muscles of respiration at the end of a forceful expiration. Or else, if the expiration is only a regular one, Dr. Monsanto, I have a class. Nagklase ko. Nagklase ko. Nag-lecture ko. Oh, sige, okay. So this is breathing brought about by increasing or decreasing the vertical, the anteroposterior, and the horizontal diameters of the thoracic cage. So breathing is more of the interplay of the respiratory muscles. If there is a pathology, for example, Myasthenia Gravis, there is a paralysis of the intercostal muscles. So it cannot pull the ribs down, and it cannot contract the diaphragm. And it cannot pull the ribs down. It cannot pull the ribs up, and it cannot pull the ribs down. Cannot let the diaphragm contract in your myasthenia gravis. Why? Because of lack of acetylcholine. I think one of you will have to report that later. This is the appearance inside the lungs, okay? Negative pressure breathing. This is your inspiration and expiration. This is your normal atmospheric pressure outside. And then when there is inspiration, you inhale, what happens to the pressure? We'll start with the end of expiration, so there is no flow. The pressure in the atmosphere is 0. In the alveolus, it is also 0. The transpulmonary pressure is 0, and the intrapleural pressure is -0. What happens? So you inhale, okay? Mid-inspiration, the air goes inside, and the alveolus pressure will decrease from 0 to -1, okay? And the transpulmonary pressure from -4 to -5, -6. So your transpulmonary pressure here is 5, okay? Because -1 and -6. That is your mid-inspiration. Then later, you inhale. What happens during end of inspiration? From -4, the pressure is -7. So your transpulmonary pressure is 7. What happens? At the end of inspiration, there is increased pressure inside the lungs. So what will happen? The air is blown outside. It will go out of the alveolus. So during your mid-expiration, your alveolar pressure is already 1, higher than that of the atmosphere, which is 0. So what happens to your intrapulmonary pressure? It will become -5. And the transpulmonary pressure 6 mid-expiration. Then your air will go out. Okay. So 1, 2, 3. End of expiration. Then end of inspiration, mid-expiration, and end of expiration. And this is 500 ml. Your normal tidal volume. When there is, for example, you have polio. So there is paralysis of the respiratory muscles. So they used to place the patient in an iron lung, negative pressure respiration. In negative pressure respiration, the air is pushed towards. This is low pressure chamber. Then the lung is the iron lung is the one doing the breathing for the patient, because the respiratory muscles is paralyzed. So you push in the air, and then the lung will also reduce. And at the same time, the muscle, the mouth will also experience inhalation and expiration. So it is the machine that is doing the pumping. It will pump air, and then the air will also go out through the machine at the same time through the mouth. In your positive pressure respiration, you pump the air. The air from the outside goes to the valve, and then it will be pumped so that it will go out through this valve. Will rotate, the moment the patient will expire, this will rotate and the air will go outside. That is your positive pressure. This is the principle of your positive pressure. It will pump the air inside, and then this will increase here, the pressure, so that the air can go outside, and this will rotate. So if oxygen is needed, it is oxygen that is being pumped inside. Okay, so this inflate the alveoli, and then pressure is applied so that the air will go outside. Okay. More or less the same with your mouth-to-mouth breathing. You apply air through the mouth and then you apply pressure on the chest with your hand, okay? So that the air will go outside. You blow air into the mouth, then you push. And that is still the principle of positive pressure. So what are the respiratory muscles that are involved? During inspiration, there is quiet inspiration, that is eupnic or resting inspiration. That's why you do not realize that you are inhaling already, because that is a reflex. That it takes place without you not being conscious about it, unless you do it consciously. Okay, so what are the muscles involved in your quiet inspiration? The diaphragm and the internal intercostals. So what are its effect? Increases the vertical diameter, because what happens to the diaphragm? It will go down 80% of the total volume. External intercostal increases the antero-posterior and horizontal diameters of the thoracic cage, 20% of the tidal volume. When there is forceful inspiration, should we say during exercise, or when you go running, so you have to inspire forcefully. What are the muscles involved? Diaphragm, external intercostals, your sternocleidomastoid, your anterior serrati, and scalene muscles, for greater expansion of the thoracic cage up to its maximum lung capacity. Or else only 80% of the vertical diameter of the thoracic cage and 20% of the anterior posterior and horizontal. That is how far they will expand. But if during forceful inspiration, this is what happens. Greater expansion of the thoracic cage up to maximum lung capacity. During expiration, quiet expiration, eupnic or resting expiration, no contraction, only relaxation of the inspiratory muscles. So this is a passive process. Normal recoil of the lungs and thorax will decrease the diameter of the thoracic cage towards the functional residual capacity. Your functional residual capacity is your relaxed state of your lungs. When you have forceful expiration, for example, you will cough or sneeze, that is forceful expiration. Voluntary, or you will do Valsalva maneuver, forceful expiration. When do you use your Valsalva maneuver? When there is a plug. For example, you'll choke from a piece of meat that you have eaten, for example. So that is forceful expiration. What happens? The muscles involved are your internal intercostal muscles, your external oblique, your rectus abdominis, transversus abdominis, and your internal oblique. What happens with your internal intercostal muscles and your external oblique? You move the anterior chest wall downward and towards the spine. With your rectus abdominis, it pushes the abdominal contents upward, thereby compressing the lungs. See? That is how the muscles come into play during the process of inspiration and expiration. Lung compliance. Compliance. The extent to which the lungs will expand for each unit increase in transpulmonary pressure. That is your lung compliance. You have also compliance in your vascular. Remember, when you took up your cardiovascular system, there was also compliance of your blood vessels. Compliance is determined by two elastic forces of the lungs. The elastic forces of the tissue itself and elastic forces caused by the surface tension of the fluid that lines the inside walls of the alveolar and other lung air spaces. This is an illustration of your lung compliance. Lung volume against your transpulmonary pressure. This is your normal. When you say you have decreased compliance, what happens to your lungs? That means your lungs are stiff, okay? If you have increased compliance, what happens to your lungs? It can easily expand, okay? So compliance is determined by the change in lung volume over the transpulmonary pressure. The change in the alveolar pressure minus the intrapulmonary pressure. So when there is decreased compliance, what is its significance? That means the lungs are stiff, okay? There might be fibrosis in the lungs, so it cannot expand that easy. Whereas if there is increased compliance, probably it's too loose. Sometimes, just like in your emphysema, can easily expand, but it cannot go back. It cannot recoil because there is something wrong with the amount of collagen. The changes in lung volume and transpulmonary pressure are measured as a subject takes progressively large breaths. When compliance is lower than normal, the lung is stiffer. There is a lesser increase in lung volume for any given increase in transpulmonary pressure. When compliance is increased, as an emphysema, small decreases in the transpulmonary pressure allow the lung to collapse. This is already your abnormal. What else? So when you breathe, you also perform work, right? Breathing involves expenditure of energy. So you work. Your muscles, they work. The work of inspiration is divided into three fractions. Compliance work or elastic work, that required to expand the lungs against the lung and chest elastic forces. Another is the tissue resistance work that required to overcome the viscosity of the lungs and chest wall structures. Another is airway resistance work that required to overcome airway resistance to movement of air into the lungs. We'll go into the compliance. The total lung elasticity is tissue elastic force plus surface tension elastic force. That is your total lung elasticity. Now we'll go back here in your compliance work or elastic work. That required to expand the lungs against the lung and chest elastic forces. Why? You have to spend energy to expand the lungs. So for example, if your lungs has a normal amount of your collagen, it is very expandable. So it can comply right away. It is compliant. Tissue resistance work that required to overcome the viscosity of the lungs and chest wall structures. On top of the alveoli, on top of the alveolus, for example, are fluid, okay? There is mucus and then there is surfactant. Surfactant is the one that decreases the viscosity of the fluid on top of the alveolar wall. Your surfactant is made up mostly of lipids, your dipalmitol phosphatidylcholine, mostly. And this viscosity is the one that will regulate the expanse. How expandable is the structure of the alveoli, And then another is your airway resistance. When the air comes in from the lungs, from the outside, it encounters resistance because remember, you have branches, okay, of your bronchos, your bronchioles, and then up to the alveolar area. So you encounter resistance during those branching because the tube is not straight, okay? So you have to work, you have to overcome that resistance. That is your airway resistance work. So you have to overcome the elasticity of the lungs, the viscosity of the surface of the alveoli, and the airway resistance, the airway. You have to overcome the branching, The tissue elastic force tending to cause collapse of the air-filled lung represents only about 1/3 of the total lung elasticity. The fluid air surface tension forces in the alveoli represent about 2/3. Fluid air surface tension. And so this is the one that is responsible for your viscosity. The surfactant, your dipalmitoyl phosphatidylcholine, reduces alveolar surface tension, and thus also the effort needed by respiratory muscles to expand the lungs. Because your lungs is already very expandable, it has lowered the viscosity, so can easily expand, okay, when the air enters from the outside. Respiratory distress syndrome of the newborn. This happens when the baby is born premature. Respiratory distress because of surfactant deficiency. The alveoli cannot expand properly because of the viscosity of the fluid-air interface. But when there is surfactant, this will not happen. And this takes place when the infant, the newborn infant, is born prematurely. Lack of surfactant inside the lungs. That's why nowadays they will already inject the mother with surfactant so that to prevent this happening, the respiratory distress syndrome of the newborn. The law of Laplace describes the relationship between the pressure, surface tension, and the radius of an alveolus. Pressure equals 2T over R. Shall we say there is no surfactant here, and then this alveolus has surfactant. Here, and TA, this alveolus is equal to TB. But since B is smaller, so what happens? The pressure here is increased. And what happens? The air here will flow from A to B. And B, what happens? Will collapse. Okay? But if there is a surfactant, the pressure is stabilized. The alveolus is stabilized. So the pressure here, even if this is smaller, is equal. So there is no flow from B to A. So the smaller alveoli will not collapse into the bigger alveoli. See? So the radius doesn't matter much if there is surfactant. Okay? As the pressure inside the alveolus decreases, the pressure, as the radius inside the alveolus decreases, the pressure increases. Of course, small alveoli would collapse into larger alveoli. So surfactant gives stability to alveoli of different anatomic sizes. Because as an alveolus gets smaller, the surfactant becomes denser and will increase the stability of the alveolus. Because you notice if this is bigger, okay, this is bigger than B, okay, and so the surfactant here is more spread, okay. As the alveolus will become smaller, the surfactant from here with this here and the surfactant will come together, so it will become denser, and so gives stability to the alveoli. That is why it will not, once the alveolus, the alveolar area of the newborn has expanded, it will not collapse anymore. And usually this is the basis for, when there is what do you call this, medical legal cases to determine if the baby was born alive and or dead, okay, because the alveolus, the alveolar area is expanded, it is filled with air, because the alveoli are stable, it will not collapse back, okay, to its former size, okay. The air inside the lungs is measured by volumes and capacities. When you say capacity, the total lung capacity of the lungs, the total, this is 6 liters. Now, when you say tidal volume, the amount of air inhaled or exhaled in one breath during quiet breathing, and that is 500 ml, and that is your tidal volume. Inspiratory reserve volume is 3000 ml. The amount of air in excess of tidal inspiration that can be inhaled with maximum effort, because you can still inhale some more after a normal breathing, right? And that is 3000 ml. It's quite a big amount. Inspiratory reserve volume, that means you can really inspire some more. That is your inspiratory reserve volume, 3000 ml. Your expiratory reserve volume is 1200 ml. That is the amount of air in excess of your tidal expiration that can be exhaled with maximum effort, because there is recoil of the lungs, remember? So expiration, the muscles will, respiratory muscles will not come into play in your regular expiration. But aside from that, you can still expire some more. And so that is your expiratory reserve volume. But you cannot really expire everything. Some air will remain inside the lungs forever. And this cannot be measured by spirometry. It is around 1,200 ml. This is the amount of air remaining in the lungs after a maximum expiration. This is the one that will keep the alveoli inflated between breaths and mixes with fresh air on your next inspiration. Your vital capacity is 4,700 ml. This is the amount of air that can be exhaled with maximum effort after maximum inspiration. So, expiratory reserve volume plus your tidal volume plus your inspiratory reserve volume. So this is your vital capacity. Okay, this is used to assess the strength of thoracic muscles as well as your pulmonary function. Your inspiratory capacity, maximum amount of air that can be inhaled after a normal tidal volume. Inspiratory capacity. So it is equivalent to your tidal volume plus inspiratory reserve volume. Your functional residual capacity is the amount is 2,400 ml or 2.4 liters. This is the amount of air remaining in the lungs after a normal tidal expiration. So when your lungs is in the relaxed state, this is your functional residual capacity. So it is equivalent to your reserve volume and your expiratory reserve volume, your residual volume and your expiratory reserve volume. That is your functional residual capacity. Your total lung capacity involves everything: your inspiratory reserve volume, your tidal volume, your expiratory reserve volume, and your residual volume. Remember, residual volume could not be determined by spirometry. So, with your, if there is residual capacity, no spirometry, right? So with your functional residual capacity, you cannot determine this by spirometry. You can just compute. What is your dead space? Anatomic dead space, the part of the tidal volume that does not participate in gas exchange, is called your dead space air. The gas exchange occurs only in the alveoli. The conducting airways from the nose to the terminal bronchioles thus contain air that does not exchange gases but the blood. So your tidal volume is 500 ml. Your normal value of your dead space volume is 150 ml. So the what do you call this? The air that is in exchange is your 350 ml. So in the alveolar gas, you have your 150 ml in the respiratory bronchioles, volume in conducting airways left from the preceding breath. Okay, so it is not all of the gases that will find its way into the alveolar area. Some will remain in the conducting zones, and that is your dead space zone. 150 ml, the normal value for that. And so, in the conducting airways, you have your 350 ml plus 150. So, anatomic dead space, that is the term for your dead space. Space that do not have exchanges of your gases, your oxygen and carbon dioxide. The minute respiratory volume. This is the total amount of new air moved into the respiratory passages each minute. This is equal to the tidal volume times the respiratory rate per minute. What is the normal respiratory rate? The nurses and the medtechs know this. 12, right? So normal tidal volume is about 500 ml, and the normal respiratory rate is 12 per minute. So the minute respiratory volume averages about 6 liters per minute. Alveolar ventilation per minute is the total volume of new air that reaches the alveolar area each minute. Okay, so it's not all the air that you inspire that reaches the alveolar area. So the alveolar ventilation is the new air, the total volume of new air that enters the alveoli each minute. So it is equivalent to your respiratory rate times tidal volume minus dead space volume. So 12 times 500 minus 150. Okay. Where VA is your ventilation per minute. So here, the effect of breathing patterns on alveolar ventilation. For example, you have your subject ABC, tidal volume, respiratory rate, minute ventilation, anatomic dead space ventilation, and your alveolar ventilation. So when you have your tidal volume, the normal is 500, right? The respiratory rate is 12. The minute ventilation is 6 liters, 6,000 ml per minute. The anatomic dead space ventilation is 150. Times 12 is also 6 liters. The alveolar ventilation is 4,200. Now, when the tidal volume is only 150, what happens? And the respiratory rate is 40. The minute ventilation is 6 liters. And the anatomic dead space ventilation is 6 liters. So the total minus the anatomic dead space. Remember? Alveolar ventilation is respiratory rate times tidal volume minus dead space volume. And so the result is zero ventilation. If your tidal volume is 1,000, your respiratory rate is 6. Minute ventilation is 6 liters. Anatomic dead space ventilation is 900. So your ventilation, alveolar ventilation, is increased. Okay. You can find this in athletes that has undergone training, physical training. Okay. And with this 150, with a respiratory rate of 40, usually you can find this in patients undergoing hysteria. You know, the ladies, yun nagpapansin. So she will undergo syncope because there is no alveolar ventilation. Okay, and this is not normal. So increasing the depth of breathing is much more effective than increasing the rate of breathing when you would like to increase your alveolar ventilation. So this is what happens in athletes to increase their alveolar ventilation. Anatomic versus dead space ventilation. And a healthy adult, anatomic dead space and physiologic dead space are equal. In some pulmonary disorders, some alveoli are damaged and cannot perform their role as gas exchange areas. So what happens? These alveoli now contain dead space air. So now that is your physiologic dead space. The anatomic dead space plus your alveolar dead space, that is your physiologic dead space. Alveolar dead space. There is no perfusion. So anatomic dead space plus alveolar dead space, that is your physiologic dead space. Normally you have your oxygen, right? And who delivers the oxygen? From the outside, and then it will go to the capillaries that perfuse the alveoli. If there is no perfusion, what happens? The oxygen will just remain in the alveolar area. It will not do its function of oxygenating the cells because it cannot be carried by the blood towards the cells, tissues. So what happens? Now this is non-functional. So physiologic dead space. Okay. That's the end. We will continue tomorrow. So you will have your, what do you call this, exam on Wednesday. And then Dr. Abueva suggested that yung topic niya, her topic will be the one covered for the exam. Okay? So 50 items for Dr. Abueva's topic quiz on Wednesday. The remaining topics of Dr. Mambolao will be included already in the bi-monthly. Hindi na tayo mag-quiz sa topic ni Dr. Mambolao. Okay? So that is already included in the bi-monthly. So your exam on Wednesday will only cover the topic of Dr. Abueva. Okay? We will continue tomorrow. I promise to be more, hindi na mapalso. More adept on screen sharing. Ano pa? What's the problem? Do you have any question or things you have not understood? Anyway, we'll cover it up tomorrow. Whatever is your question, yun. Yes. It is always given to you. Everything. So that you don't have any reason to fail. Yeah, because this is the basic. And you know, with these PowerPoints we are giving you, you keep this until the end when you graduate, because you can already use this. If you would like to go into teaching later on, you can use this, and then you just, what do you call this, update, update later on. But do not give this away. This is exclusively for you. Do not give it to your, not to your competitors. Who are your competitors? The students from other medical schools, not your classmates, because you belong to a family. So you are one, okay? So you share each other. Huh? Ganon. That's why we give you all the slides so that you will have a file yourself. Okay? Ano pa? What else? Any concerns, wise or otherwise? Otherwise. Pwedeng otherwise. Any concerns? Yun ang sinabi ko. You look for the answers of all the exams. Sharo, you have only 50 questions for the quiz and then 100 questions for the bi-monthly. The bi-monthly, we usually get from the quizzes. The finals, we usually get from the bi-monthlies. You have 400 questions already, question bank. So there is no reason you cannot answer. But sometimes, you know, the principle is there. Ano, wala na. We'll continue tomorrow. So we're done for the day.
Good morning, Doc.
Doc.
Doc, may question lang po.
Yes.
Oh,
Thank
regarding
you po,
po,
Doc.
regarding po the laboratory po. If the situation po does not permit for a face-to-face po, how will it be for the laboratory?
Kaya nga, may report kayo. You will, for example, here in pulmonary, I will not discuss the clinical correlation. You be the one to discuss so that I can give you a grade. That is a substitute for your laboratory already so that you can cope up, okay? That is equivalent to your laboratory grade, like that, okay? Instead of a small group discussion, because it is difficult to be doing small group discussion with Zoom. You just divide yourself into groups. You're already divided. You already have your groups. Divide yourself into 10 groups. Huh?
According to Ma'am siya po, kayo po yung mag-group daw sa amin for the for fish show.
Mag-ano?
Kayo po yung mag-grouping sa amin for fish show according to Ma'am siya. She mentioned on earlier.
Your coordinator will be the one to do the grouping.
Okay po. I'll ask her na lang po about it.
Yes, and then only 10. Yeah, you are 100 plus, right? So there are groups that are more than 10 for each group, diba? Parang ganon, only 10 groups. So that means some are 11 or 12 members, okay?
Hi, Anne.
Yes.
Doc Aboyba here. As to
Yes.
groupings, alphabetical na lang, so it's easier for recording.
Yes.
1 to 10.
Just like last year.
Yeah.
Oh.
Alphabetical na lang ang grouping from the attendance sheet, so it's easier for us in doing the recording of the activities. Like example, number 1, say Abalos. So the first 10, so isang group yon. Then 11 to 20, another group. Para to facilitate also in the recording. Kaya lisod ba na magsige kag jump from magsige pangita hain naman ni sikuan nga group. So ganun na lang ang grouping. It's the usual how we do it.
Yeah, that is usually what we do. Diba?
Then just select a leader from that group. Each group should have a leader. Ganun na
I
lang
will assign you tomorrow the what do you call this, clinical conditions, and you will be the one to discuss that.
Doc. Hello, Doc.
Yes.
Mr. Bargamento po, Doc. Doc, we have actually all groupings po, Doc. Can we use that or alphabetical still?
You already have a grouping? In what subject?
Yeah, for other subjects po, Doc. Research, embryo, and
Is that
anatomy.
alphabetical? Is that
No po, Doc.
alphabetical?
No, Doc.
Iba na lang sa FISU, alphabetical.
Okay, Doc.
And
Okay,
then
Doc.
you distribute the medtechs. Kailangan in one group there should be a medtech. Okay?
Okay po,
So
Doc.
you take i-separate mo yung mga medtechs and then you distribute the medtechs in different groups. Okay?
Noted po.
Just in case we will be able to perform laboratory within the second semester, then we don't need to reshuffle. The medtechs are already in place. Okay. You do alphabetical grouping, and then what do you call this? Except the medtechs. Okay.
Okay po, Doc. We'll divide it na lang po.
Oh, and then i-ano ko ngayon, I will send the instructional objectives. I-email ko sa, sino ba yung coordinator? Coordinator ninyo?
Joanne Rueda po.
Ha?
Joanne Rueda po, Doc. I can message you po sa messenger na lang po since nag-chat na po tayo before.
Ito ba si Rueda?
Yes po, Doc.
Joanne?
Yes po.
Yes, I will send you sa email mo. Nandito na, I have your email na. I will send you this afternoon the instructional objectives. I-email ko na lang.
Yes po, Doc. Thank you.
What else? Just be sure that you read. You read all the topics and then you master, especially the principles. The good thing with physio is it has a story. Physiology has a story. It's not as abstract as biochemistry. Although biochemistry now has a story, unlike during our time, na mag-memorize talaga kami without understanding. Just pass. Kasi Dr. Abe ba, mahilig yan mag-memorize. Yeah, so okay na. Kaya top 10 ito si Dr. Abe ba? Mahilig mag-memorize, lalo na sa anatomy, nako, number 1. Kaya huwag kayong magbiro-biro sa kanya. Because she knows. Barkada niya ang mga bacteria, virus, parasites. So you will still meet her in the second year. Magbarkada kayo doon. Together with the bacteria, the parasites. Dito tayo sa
Normal.
Yes.
New normal.
Mga normal, Then this is a new normal now. Just be careful. Stay safe. Mas mabuti kung if you'll just stay in Tacloban already so that you won't have a hard time with your internet connection. Yeah. I encourage you, if you are from Samar and you have difficulty in your signal there, mas mabuti you stay in the boarding house. At least you are safer there. Kaya you don't have to go anywhere. Diba? Oh. And then the internet signal is okay. So, hindi kayo mabitin sa mga lectures. Diba? Yan na, alas 12 na. We'll have lunch already. Magdungan ta. Okay. Call it a day. See you tomorrow.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Thank you, Sha.
Doc. Ay, mamabi pa. I-end ko na, Doc. Bye-bye.
Yes.
Bye-bye, Doc. Thank you.